Okay, we are a few minutes past 9 o'clock, so colleagues are still joining us, but I think we'll make a start and people can come in as we get going. Good morning, everybody, and welcome to the next instalment of our webinar series on our program of support for elective recovery in mental health. Today's session is on patient tracking. For those of you who are joining us for the first time, there will be some interactive portions of the webinar where we use a system called Menti to poll people for anonymous responses to questions. The QR code on your screen will be scannable via a mobile phone, and that will take you through to the web page where you can access the portal that will iteratively update itself when we get to the different questions where we are asking for audience participation. If you don't have access to a smartphone, you can go to menti.com and use the code that is displayed on the screen in order to access the questions. And if you leave a window open with that in, it will update itself as we go through. As per all of these webinars, the slides, the video recording, and all of the tools and resources that we talk about today are all on the Mental Health System Improvement Future NHS page, which one of my colleagues will be linking to in the Q&A function. So please do register if you are not already registered, because that's where all of our materials live. My name is Simon Bristow. I am a system improvement advisor in the mental health intensive support team, and it's us who are hosting this webinar and this series. I'm a mental health nurse by trade and have worked in lots of different aspects of provider land prior to joining NHS England. Can I have the next slide, please? So again, please use this QR code to register if you didn't manage to get to it on the previous slide, or if you're just joining us. If you can't do that, then please go to menti.com and use that code on the screen. This is going to be an introduction to the resources we've produced around tracking patients in their journey through community mental health services. As per all the other webinars we do, we will have a Q&A session, and there's a Q&A box, so please do put comments and questions in throughout it. And at the end, we'll have about half an hour to take questions. And we put these resources out prior to winter to assist with the winter planning ask. And in the spirit of improvement, we are working with colleagues in various systems around the country to refine, improve, and update them. So they are a kind of piece of continual work in progress. So please do engage with us. Tell us your ideas for changes. If there's anything you think could be clearer, better. We are always looking for ways to improve them. Can I have the next slide, please? So what we're going to cover today is patient tracking. It's a huge topic. There's going to be more than we could possibly get through. We're going to give you a high-level overview of the various mechanisms and the tools, and then take a real detailed focus in on the setting standards, monitoring data and outcomes, and making improvement portions. And that's going to include reporting on which patients are receiving what, from whom, why, and for how long, using the data that's generated to understand and respond to the issues identified, where you can get the resources, how we can support you, and an opportunity to ask questions of the team. And as I said on the first slide, detailed guidance on all of the specific interventions and best practice for each is available on the Future NHS page. So we are the mental health system improvement, mental health intensive support team, and we're a small expert quality improvement team of people who are all senior managers who support the NHS to deliver improvements in population health, quality of care, and value for money in mental health care. We've all got expertise in healthcare management and have spent many years, more than many of us would care to count, working to operationally deliver mental health services, leading change around service delivery, and a number of us come from elective care and acute backgrounds who have an in-depth knowledge of the design and delivery of waiting time standards from the sort of 20 years or so that has been being worked through in elective care. We also have a number of professional registrants within the team who have specific and significant experience of being experts in their field and provide advice on care in relation to clinical interventions, how to work clinical governance, policies, etc. And as you've probably picked up from what I've been saying, we've got a varying a range of backgrounds covering lots of different aspects of service provision. Can I have the next slide, please? So the program support for elective recovery is a suite of resources that we put together to help systems to use quality improvement methodologies to improve the delivery of community-based services post-COVID. So it's around quality, experience and outcomes through improving access, waiting times, and how we use clinical resources to deliver best practice. The kind of underpinning aspects of all of them are around tracking activity, identifying where your issues are, and using that to undertake targeted data-informed improvement work, sort of moving from beyond anecdote into what we can evidence. And we've worked up this suite of resources from our understanding around what does and doesn't work in community mental health delivery, from working for 6 years supporting systems that were struggling to deliver the standards around EIP, children, young peoples, and IAPT, and then another 18 months or so that we spent working with the 4-week wait pilot sites in children and young people's mental health services, looking at systems that were at the other end of the spectrum and were delivering quite short waits and effective flow. And obviously we've got some elective care colleagues in the team, so we have used a number of the methodologies that have been well established, tried, tested and refined over the last 20 years in elective care and modified them so that they are applicable to mental health settings. Can I have the next slide, please? So very briefly, there are 7 modules, and they are divided up into specific spaces that are all hosted within the Future NHS platform. There are webinars on each, as well as an overview webinar that we did at the beginning. Please do check it out on the Futures space. There are forthcoming webinars also. We've got one on the 31st of Jan on access policies, and one on the 21st of Feb on commissioning to optimize delivery. You can find the recordings of all the sessions that we've done previously on the Futures platform. So without further ado, I will hand over to Mr. Michael Watson, our resident patient tracking and waiting times expert and previous head of elective recovery. Michael.
Thank you, Simon. Good morning, everybody. So, as Simon said, my name is Michael Watson. I've been a member of the team since it started back in 2014. And prior to that, I spent 5 years working in the intensive support team for physical health, so RTT, cancer waiting times, and so on. And prior to that, I've actually had the job title of patient tracking manager in an acute trust, amongst other ones. So this really is something that I've had a fairly significant experience of managing acute trust through the delivery of waiting time standards various. And as Simon said, during the pandemic, I was redeployed as head of elective recovery in my local acute trust. So I do also have some fairly recent experience of the delivery of patient tracking and waiting times management in a large organisation. So we always ask you at the end of our webinars for feedback, and we like to demonstrate that as improvers ourselves, we're always keen to act on it and make our own products better. So we asked you what was good last time, and we heard about the balance of the webinar and getting others to speak. We've endeavoured to continue that. What could be better? More detail about how to implement. So we have gone deep on the implementation and templates and things this time. So if we've gone too far, then please do let us know in the feedback after this webinar, but really you've only got yourselves to blame. You wanted to hear, to help you go further, what the process for getting to good looks like and how other trusts are approaching this work. So again, we've talked quite a bit about, or we'll talk quite a bit about the process, and we've also invited Paul from Leicestershire, who will talk a bit about how this process evolved within his trust. So you've got that to look forward to a bit later. Next slide, please. So patient tracking is kind of one part of the delivery of rapid elective pathways. We talked before about elective care, so as distinct from urgent and emergency care. So elective care being when there is an appointment where care is planned in advance in an outpatient setting in this instance. So you heard before from my colleague Nick about managing backlogs, appropriately sized waiting list, and about pathways capable of delivering appropriate interventions within maximum waiting times and capacity and demand back in October and November webinars. Obviously, Simon talked to us about patient flow in general in December, and now we're kind of at the other end of this whatever we're calling it, spectrum, looking at making sure that we treat people in the right order and that we proactively manage people through their pathways. Next slide, please. Just to show that this isn't something that's completely made up, although as Simon said, it's been well used in elective care for at least 20 years. Regrettably, I've been doing it for almost that long as well. But there's also some recent research evidence which kind of supports the key factors in terms of delivering shorter waits for patients. There's the report from King's Fund that came out just before Christmas and talks about what the key factors were in the delivery of 18 weeks. And think of that what you will, but there's no doubt that the number of people waiting feels a bit ironic now they're up to a national waiting list of 7 million, but for some time the number of people waiting for elective care reduced and the amount of time that they were waiting reduced very significantly after its implementation back in 2008. And the key success factors that they identified were increased funding and capacity. It might not be where you want it to be, but through the 5-year forward view and the long-term plan, there's no doubt that there has been significant increased funding in mental health care. Central direction and oversight. I'm sure a number of you have received quite a lot of documentation from the National Policy Team in recent years, both in terms of waiting times guidance and more broadly in terms of implementing models of care. Performance management and incentives. And that's a lot about what we're going to talk about today in terms of a PTL process, waiting lists, and proactive management. Targeted support, which is effectively the role that our team fulfills, and we are available to help. And Simon will talk a bit later about how we can help you in your organisations and systems. Leadership and relationships at all levels. Obviously, that's true pretty much whatever you're trying to do, but it's particularly important around waiting times program that you've got that vision and senior sign up to get the oversight and to unblock some of the really sticky problems that can't be resolved at a kind of local or team level. Mobilising know-how and skills on the ground, and we hope that our resources on the future site can help you to do exactly that with our support if you require it. And finally, wider NHS reform. Anyone that's worked in the NHS for even a minute will know that that's more or less a constant thing, but certainly, again, the kind of focus and energy from the National Policy Team, new delivery models, new ways of working has had more of an impact recently. So we believe that all of the kind of criteria are in place to be able to deliver shorter waiting times for people in mental health services. We would encourage you to follow this good practice to try to deliver that for your patients. Next slide, please. So what are we going to get today? I'm going to talk to you about what a PTL is, because I know it's a term very commonly used in acute care, but less so in mental health. What you call it is really irrelevant, but we're going to call it a PTL for consistency and simplicity. What it can do for you, why it's important, what it looks like, what you should be tracking, how you should be designing waiting times where you need to, and how you know that what you're doing is working, amongst other things. Next slide, please. So, starting from the beginning, what is a PTL? So PTL is used fairly generically to describe either a PTL report itself, so effectively a list of people waiting for something, possibly produced in a tabular way, depending on who's looking at it. It can also be used to describe the meetings associated with that list of people, so basically the meetings where you talk about who's on the list and what it is you're going to do to help them through it, and the kind of governance around it, whether that's escalation processes, whether that's an oversight board or whatever else it might be. All of that can be interchangeably described as a PTL, and people use it as such, which can cause confusion if you're not familiar with it. So a PTL is a forward-looking tool to manage waiting lists to achieve waiting time standards. Forward-looking being crucial here, because we're not trying to just measure what we've done before, we're trying to make a difference to what can happen next week, next month for people waiting. So what can it help us to achieve, or help you to achieve? It can help you to give you a regular view into your governance process, what's happening on the ground, how long each person's waited for the next step of their treatment journey. So as Simon said at the beginning, who's waiting, what they're waiting for, and when they need to get it by. Make sure that people are treating in turn rather than individual decisions being taken, which might be inconsistent from one team or one clinician to the next, subject to clinical urgency, obviously. To help coordinate across the organisation so you don't have lots of different people and teams working in silos and pulling in different directions. To identify where individuals are getting close to their maximum waiting time so that you can act for that individual and do something about it, but also to identify where groups of people are getting close to their waiting time so that you can take slightly more strategic action. And also to help to kind of routinely and as part of business as usual, validate and update your waiting list to make sure you get that organisation assurance that you know who's waiting, that you haven't got people in silos, you haven't got random little Excel spreadsheets that only Jack and Jill can access when they come in on a Tuesday and a Thursday or whatever else it might be. Having a single central record and organisation assurance that what you're looking at is accurate. Next slide, please. So why that's important. So as I said, having an accurate view gives you the ability to proactively manage people through their pathways and supports good pathway flow, as Simon talked about back in December. Gives you an early warning about if things are not working well so that you can act and nip things in the bud before they become a real problem. Gives you a heads up about forthcoming capacity issues and lets you have focused discussion with individual teams and clinicians to tackle pathway issues and try to carry out some really meaningful service improvement work where it will have the greatest impact. And in terms of governance and assurance, as I said, it's really important for you as managers to get assurance that your waiting times are accurate and that people aren't being missed and that people are being treated in the right order. And it also gives you assurance organisationally that the processes underpinning the PTL, so for example, booking processes and various other administrative tasks, are working properly. If they're not working properly, that will come up through your regular PTO discussions. And at an exec level, it gives you that oversight and governance so that you can be assured that things are working and that the strategic goals that you've set for yourselves as an organisation and the system are actually delivering and moving in the right direction. And it eliminates the need for validation of waiting lists and other kind of tedious administrative processes, because as long as you're using your data on a daily and weekly basis, then it will de facto be up to date and accurate. Next slide, please.
Right.
I'm going to pass over to Francis. Beg your pardon, Francis. Pass over to my colleague Francis for our first mentee of the day. Buckle up.
Well, I'm ready to go. I don't know whether you are. So definitely, please use the QR code there, and hopefully you've got your fingers at the ready. So we've got your first question for you, just to test that it's working, which is, in your service, do you have access to a regular detailed list of everyone who is waiting? And how have you configured that? Is that for assessment, first appointment, all pathway stages, including subsequent interventions, or do you just have a list on your EPR or no list at all? Well, so far, I think the first two responses are the most popular, mostly just equally for first assessment, first appointment. And some of you have a PTL for all pathway stages, including subsequent interventions, which is great. Would definitely like to hear more from you in terms of, how you got there, and equally from those who are trying to implement to sort of share what your barriers are. So definitely, it looks like the first one, Michael, is the most popular for assessment and first appointment, and shortly after for all pathways and stages.
Thanks,
Pop
Francis.
your questions in. Thank you.
Yeah, and that doesn't really surprise me. Certainly, my experience, and I imagine other team members are nodding along, it's very common for us to encounter relatively okay processes around managing that first appointment, but then things tend to get a little bit more murky as people get deeper into their pathway, so to speak. Right, so what is a PTL report? So, as I said before, it's basically a list, usually representing visually the shape of that list. And a bit further on, I'll show you a couple of examples. And so it should contain everyone on an active pathway who's waiting. As we said before, not just people who are waiting for their first appointment, but people who are waiting for other things as well. And to be clear, we're not talking about if someone's going to, doing a course of 12 sessions of some intervention, you don't necessarily need a waiting list for every single one of those 12 sessions. You need a waiting list for the start of that course of treatment. It should be refreshed daily and easily accessible. So as I said before, we don't want lots of hidden spreadsheets that have only got limited access in a shared folder that only works occasional days. And it should be ideally online and certainly issued regularly so that everybody in an organisation has an appropriate level of access to it. And it should give you the right level of detail so that you don't generally need to go outside of the report in order to take action. So it should tell you who the person is, what's happened to them so far, what they need now, and what needs to happen next. It should be designed so people can sort them easily, so they can sort them according to their own particular priorities, but always with the same breach dates and key target dates. And managers might find it helpful to be able to sort it by team and by clinician to try to help them to identify where the kind of potential blockages in pathways are. Next slide, please. So in terms of the principles of what goes into it, and these are pretty generic principles in all honesty about what a good report should look like. They should be accurate, and if there is anything that's not working, so any issues in your EPR or any booking problems, they need to be clearly highlighted so people know what they're looking at. They need to be checked and analysed to make sure that people understand what it is that they're looking at and what any actions they take might do to that data. The way that they look should be developed in collaboration, and it's really important to get good working relationships between your informatics or IT teams and with your users of the reports to make sure that they're doing the things that they need to do and presenting the information in a clear way. As I said before, they need to be timely and up to date. They need to be exception based. So what we're looking for in a good report is where you can highlight of the potentially in some organisations thousands of people waiting for something, who the people are that require action today and who the people are that are going to require action tomorrow, not all the people that got referred last week that aren't going to come to the kind of tipping point of your list for potentially weeks or months to come. They need to be consistent so that everyone's looking at the same measurements and the same KPIs, and obviously they need to be secure. So you're not sending out lists of people's names and addresses to 7,000 people in your organisation inadvertently. Next slide, please. So I mentioned that they need to be have appropriate kind of filters and ways of kind of rationalising them so that you're looking at the people that are most pertinent to you. So you need to be able to filter it down by particular team, particular interventions that people are waiting for, particular clinicians potentially, depending on the level at which you're working, how far people are away from their target date, how many weeks they will have waited at their appointment. So if I'm 12 weeks away from my target date, for example, but I've got an appointment in 16 weeks' time, there's no point in putting me in a green category, because really you're just waiting 12 weeks until I become a breach, and then everyone gets panicking. If my appointment is already ahead of my target date, even though my target date is some way off, action needs to be taken now to bring my appointment forward, not to wait until the worst has happened. And finally, looking at particular pathway milestones. So where someone is along the pathway, are they waiting for their assessment? This is the what are they waiting for bit. Are they waiting for their particular treatment? Are they waiting for a subsequent intervention? Are they waiting for whatever else it might be? Next slide, please. So I mentioned before, example. Here's an example from an organisation about a kind of, and this is a fairly sort of typical approach to a PTO report. So as you can see along the top, there are lots and lots of filters, so you can very quickly get it down to, depending on which area of an organisation or a service you're managing, you can very quickly whittle it down to the ones that you're interested in and that you need to deal with, that's under your responsibility. And then we've got a kind of a table or a grid showing all the people that are waiting. And you can very quickly see there are a number of people waiting there, probably a couple of hundred in total, but you can quite quickly identify where the long waits are and which ones you need to be focusing in on. And the beauty of any decent PTO report is when you've got that grid with the numbers, you can click on the number, and that gives you the list of patients, tells you who they are, what they're waiting for, which clinician they're under, which team they're under, etc., etc. So that you can put all the information at your fingertips to try and say, right, what can we do about this group of people? And that's the kind of key to effective PTO management, is getting quickly to the nub of the problem and having enough information to be able to take immediate action. Next slide, please. I know I'm kind of rattling through this, but as Simon said earlier, this will be recorded, or is being recorded, and will be available on our YouTube thing. And all of these resources, including checklists like the one that's on the screen at the moment, are available on our future NHS site, the link to which is sprinkled liberally around this presentation, and you should be able to access that easily. This is one of the first kind of checklists. I'm not going to go through it one at a time, but it's just some key questions to make sure that you can answer when looking at your PTO reports, to assure yourselves that they're giving you all the information and all the insights and all the different views that you need in order to be able to manage your patients proactively and effectively through their pathways. So I'm going to hand over to Paul from Leicestershire now, who's going to give you a bit of a view about their experience over the last few years of implementing PTO reports and processes, and some of the key kind of pitfalls and benefits that they found. Thanks, Paul.
Thanks, Michael. Good morning, everybody. Just to introduce myself, my name is Paul Williams. I work at Leicestershire Partnership Trust. I have operational responsibility for CAM services, amongst some other services. I'm a mental health nurse by background. So I want to just share with you sort of a few slides looking at sort of what we've done, what it looks like, and what's been the impact, really. Just to give you some context, we started PTL within CAMS 4 to 5 years ago in response to a CQC inspection that found us to be inadequate for responsive. As you can see from this slide, demand capacity is intrinsically linked into PTL, so it's really important that that's considered as part of that. So life before PTL probably wasn't quite as chaotic as the picture depicts, but it was fairly close. So whilst we had a crude analysis of numbers coming in and out of our service, we really didn't have an understanding of any sort of trends, fluctuations, what our internal weights were, what our discharge rates were, what our DNA rates were. There were lots of surprises. We had plenty of cupboards of chaos and drawers of doom where people would have sort of Excel sheets of or scraps of paper with little waiting lists on them. We had some issues around our demand capacity in terms of people's sort of ledger and diary management. So people would either have a combination of paper diaries, Microsoft Outlook diaries, ledger diaries, or a combination of all three, which made it very difficult to see what was going on. And all of that really led to a lack of confidence internally and reporting externally that we had a handle on our waiting lists at all. I should just say the EPR that we use in Leicester is System 1, but I do have some experience of Rio as well. So I'll be aware that I guess people on the call will have a range of different EPRs that they'll have access to, and some people may still be paper-based. Next slide, please. Okay, so we've been on a journey to establish a functional PTL. So we sort of started as a bit of an iterative QI process, but the foundations for it were really around job planning for all of our clinical staff, and this was something that was quite scary, I think, to a lot of the clinical staff within CAMS, probably medics aside. But we used a methodology to make sure that all our staff had an agreed job plan, which meant that we could then align that to the clinical ledgers and then align the ledgers to create some real-time reporting in terms of slot availability, etc., as well as building some reports out of the back of System 1 that could show us how long people have been waiting for each of the waiting lists. I think it was really important at this stage that we sort of got everything out in the open. So it was really encouraging everybody to sort of come forward with any of these sort of waiting lists that they had, because if we knew about it, then we could do something about it, report it, and manage it. So it's very important that we sort of all worked as a team to do that. Along the way, we've had some challenges, COVID being an obvious one. We've had some workforce challenges, as everybody on this call will have had, and that sort of impacts on the ability to maintain the PTL, but also to predict accurately recovery trajectories and things like that, because a lot of recovery is often based on availability or recruitment of staff. Increased investment's been welcome, but also a challenge, because we've had to set up new teams and set up new reporting and new waiting lists, etc. So it's been a real work in progress for us. Next slide, please. Okay, so what does it look like? So we started off with people physically in the room, and I think it's important that there's a few key people that need to be there. It's really important that we have a chair that's sort of independent from the actual service delivery, so to ask the obvious, ask the questions, and also to be able to escalate things up outside of the service line. Probably the most crucial people to be part of PTL is a business information analyst. That's really crucial in terms of being able to build the reports, walk us through them, analyse it, and take any questions on that. Ops and clinical leads obviously are part of PTL, as well as our admin management leads as well, because that's quite important in terms of slot allocation, etc. So as Michael said, we discuss a variety of things during PTL. We're looking at our waiting lists, our internal ones, our external ones, trends, how many people on our waiting list that are backing out towards or exceeding the maximum length that have got booked appointments and who hasn't got booked appointments. We are looking at our DNA rates. We're looking at compliance with our self-imposed tolerance limits for waiting lists, looking at managing our capacity. It's really a performance management process, if you like, of the whole of the service and how it's performing. Whilst we can look at actions that we can internally take to remedy certain pressures within our service, or to escalate things that we aren't able to manage ourselves. In terms of preparing the information, our business information team prepare a report on a weekly basis that's shared with the PTL team. But in the PTL itself, we look at the report live, and as Michael showed earlier, that's linked. When you click into the data, into the figures, you can actually pull up patient level information, so it's live data. We do share some of the data with the clinicians in the service. So in terms of the PTL report, we share that. And we also share some granular detail around compliance with things like care planning and risk assessment compliance. So basically at patient level detail, who's got care plan in date, who's got risk assessment in date, when are they next due to be reviewed. So that's been a helpful thing for our staff. And we share that. We've shared it in a variety of ways. We usually share it over email, but we've also done some sort of periodic newsletters to the service, to the clinicians and admin within the service, just to show people what our PTL is achieving. Next slide, please. So the impact on all of this has been, well, certainly initially we were making some really great progress with reducing our waiting lists. It's probably fair to say that since COVID, we've probably started to move in the opposite direction in some areas. I think what it does, it gives you absolute clarity on your waiting list in real time. And one of the things we've really noted is that as we've made progress and put some actions into reducing waiting lists in one area, you often get a sort of a bump in the carpet in another area. So particularly in the internal waits, if you're addressing external waits. But having that ability to see the pressure points within the system is really helpful and enables then proactive management of that to take place. And that's particularly worth thinking about in terms of reducing avoidable harm for those people who are waiting. I might come on to that in a bit. It allows for us to look at some trend analysis. That's been really helpful through COVID. So we've been able to sort of look at seasonal demand within the system for certain pathways. So, for example, we know that we get an increase in referrals around exam time and start of the academic year, and we can then predict where the trend in those referrals and the conversion rate into certain pathways is likely to be. It enables us to set some tolerance limits for our waits, because actually it's not efficient to have 0 people waiting, because then you have unused slots on ledgers. So it's most efficient to have a small waiting list, and analysis of that we can understand what the tolerance limits are. We're also able to have a look at our treatment pathways, particularly if treatment dosage is exceeding. Within mental health, that does happen, and we would expect that to happen for a percentage of our patient cohort, but it enables us to look at that in a bit more granular detail if there's a pattern of treatment dosage exceeding. So we might want to sort of examine then the reasons why. And I think the other impact, one of the biggest impacts has been that the clinical staff in the service are really clear about what the expectations are regarding their clinical capacity. I think prior to doing the job planning and PTL, I think there was a lot of anxiety about people that job planning was going to be a sort of a performance management tool for staff to sort of kick people with. I think the actual experience of staff has been completely the opposite. That people are really clear about what the expectation is on their time in terms of clinical availability. We don't expect people to exceed that, but we do expect people to work to it. and I think that's been really welcomed. Next slide, please. So the benefits of PTL for us have been that, yeah, we can compare our trends and set recovery trajectories, and that's probably more important than ever at the minute. We've seen a real impact from COVID in our CAMS referrals and the subsequent impact on our internal weight. So that's continues to be helpful to us, and it means that we can set our recovery trajectories with a degree of confidence, because we've got the demand and capacity planning in place. We've got a PTL that is managing effectively the waiting list, ensuring that people have booked appointments, that we're not wasting slots. It has proved a really helpful tool to, as I said, not only to sort of discuss internally and for our staff to be clear about what our waiting lists are and the demand and capacity in the service, but has also helped us in terms of being able to negotiate for additional investment to address some of our backlogs. So certainly before the last round of MHIS investment, we were able to make a business case, a successful business case to our local system for added investment. It obviously gives us assurance that we know what's going on in our service, and that's really important, I think, to everybody on this call, that that there aren't any hidden patients that we don't know about and that are just sitting there on waiting lists that nobody's managing. We can see situations that are developing, flex our workforce accordingly. So again, that gives us the ability to be a bit more proactive with that. The next benefit, I think, has been a really, really key benefit, connecting the staff with the data. We've really found that the staff within our service really, really love having data. I think it just gives them some confidence that they absolutely know what's going on in the service. I think without that data, people just myth and rumor abound about how many people are waiting. It all feels rather overwhelming. So to have absolute clarity on numbers is really important. And it gives some confidence again about the productivity of the workforce. So again, externally and internally, people are clear about what it is that we can offer, what our capacity is. Next slide, please. So COVID's had an impact for us. Our PTL's become virtual rather than being physically based. I think we'll probably move to a blended model going forward. It has allowed for us to monitor the impact of COVID on our waiting lists, and that's been quite important for us in CAMS, because when schools closed and then reopened, that had a significant impact on our referral rates, and so we were able to monitor that, plan for it, and anticipate the knock-on impact onto our internal weights. And then lastly, it's allowed for us to sort of monitor our productivity with the sort of blended model approach, because obviously with people working more disparately, it just gives us clarity on what's happening with people's job plans and their ledgers. So it's very transparent. Next slide, please. So in terms of challenges, I think probably keeping it fresh and relevant is a really key one, because looking at data week in, week out is quite easy to sort of almost become complacent with it, and it not really feeling as relevant as it was. So what we try to manage that by having a different focus on our PTL each week. So we'll always have some core focus on our waiting time for initial assessment and 2 or 3 of our core internal weights, but we will also try and freshen it up by having some other deep dives into other aspects of PTL that we wouldn't be able to cover off every week. So I think that's quite important to do. Being responsive to emerging risks is a challenge for us, because there are so many challenges out there at the minute in terms of emerging risks. It's quite difficult to be responsive to all of those, because we are trying to prioritise and flex our workforce in so many different areas at once. And as I said, with workforce pressures, there are challenges around configuring the system to update new teams coming online, new pathways coming online. So there's always challenges in the background with our IT guys and making sure that we have have a workable PTL for all our pathways. We do have some challenges at times because of the demands on our business information team. It probably is true of all trusts that sort of business intelligence and information is sort of one of the fastest growing areas of work in the NHS, and so the pressure on those teams is enormous. So that is a challenge for us, and for those guys in terms of being able to produce us the data. We do some clinical validation as part of our PTL, so we will look at people who are waiting or perhaps who have exceeded maximum wait times for particular pathways, and we'll do some clinical validation. So by that I mean if we have people that perhaps on a pathway for anxiety and they've been waiting on that pathway for X number of weeks, we might go in and do some clinical validation by contacting those families to see if they still need to be on the pathway. And one of the other challenges is just to keep us being solution focused and creative, particularly when things are difficult. I would, if I'm being honest, I think we're in a part of our cycle at the minute of PTL where we've got a lot of challenges. We've got some significant waiting times in our services, and it's just keeping the energy going to keep solution focused and creative. Next slide, please. So in terms of the future, I think we're still evolving. We have rolled out this methodology in other areas. So all of our teams within CAMS, so we've got various specialist teams within CAMS now have a PTL, functional PTL, with the same methodology, and that's really helpful because then we've got consistent reporting and we can sort of link those together. And we've expanded that out beyond our CAMS service into other areas of mental health. It's been really helpful and will continue to be helpful in terms of tracking the impact of mental health investment. So you can use the information from PTL to actually give some quantitative data about the number of patients seen, how long they're waiting, etc. I think that's probably going to be more useful than ever as we go forward with mental health investment, because I think there's a greater emphasis on outcomes of the schemes that providers are delivering. We're starting to use it to demonstrate the impact of wider system pressures. So that might be around things like transition to other services. So you can use PTL to look at, for example, how many in CAMS, how many over 18s we've got sitting within our service that haven't been transitioned. You can look at the impact of other providers that might refer into the CAMS service, and any issues they have, you can demonstrate the impact on the service. As I said, it's useful in terms of forecasting our post-COVID waiting time recovery plans. And we've also started to, and I think we'll do more development of using the data in greater detail. And again, this is part of keeping it fresh and relevant. So we will use PTL to also analyse. We can analyse some demographics of the people that use our service. We'll also use PTL to look at, for example, what percentage of our assessments get converted into a subsequent treatment pathway, etc., and how many don't. And that helps us again with our forward planning and conversations with system partners. I think that's probably my last slide, Michael.
Thank you very much, Paul, for that. And for those of you, if I didn't introduce myself, my name is Frances and I've been working in the team for 6 years. I think it's really helpful to hear Paul's experience of where you started building the PTL and the processes around it. And so we're going to get into the processes a little bit in this section now. And I see that you're all now becoming familiar with using the Menti. And so the question is, do you have a PTL access or waiting times meeting in your service at the moment that you recognise, and sort of what level it covers, whether it's the whole organisation, team, or whether you don't have a meeting at all? We'll hear more about the significance of this in the next section, but it seems like the majority, and please don't be shy, there's more than this number of people on the call, but the majority of people are saying that there are no meetings in place at 14. And there are sort of, for those who have meetings in place, it covers different levels. You have a whole organisation and a team one. So yeah, should we hear more about that?
Thank you very much, Francis. So yes, interesting that a lot of people don't have a meeting. I hope you've kind of taken the message, if not from me, then certainly from Paul, about the benefits this really can bring to people at all levels of the organisation. That getting together and talking about the problems and having a shared understanding of how many people are waiting and what it is they're waiting for is a really important step in terms of kind of trying to move beyond that sort of feeling of panic and chaos. So this is obviously not prescriptive, but this is a kind of an idea about a sort of an example governance structure for how you might be able to manage your waiting times. So no, excuse me. I mentioned at the beginning, and as a result of that, the output of that King's Fund report about the importance of having leadership. And so for a successful organizational waiting list reduction program, we would recommend that at the kind of organizational or system level, you have a sort of access or wait board or whatever it might be called, which will be chaired by someone at exec level to give you that oversight and to give you that support to get some of the kind of sticky problems addressed. That's fed into from your organizational PTL meeting. So that's a kind of a trust level or provider level, depending on the type of organization you work for. Where you've got people who are able to see the bigger picture across the organisation, and then that's fed into from individual PTL meetings for each bit of your organisation. And obviously, different organisations will be structured in different ways. That can be a service level or a team level, or however it is that you kind of structure that. So each of those teams has their own PTL meeting that feeds into an organizational one, and that feeds in, and that will be weekly, and then that feeds into kind of a system-wide board. And as you can see from the little arrow at the side, escalation goes up that tree, whatever you want to call it, and feedback in terms of actions taken comes back down again, so everyone knows what's happening and they're pulling in the same direction. Next slide, please. And that escalation is really important. So it's important for agreed actions to be followed through in each meeting, and that where it's not within the gift of the people in that meeting to deal with something, they need to feel confident about who it is that they can escalate to, and they need to feel confident that that person will receive that escalation, act upon it, and then feed back to them about what's been done. And that works from the kind of service level all the way up to your system level. You need to make sure that people understand the importance of that, but also that people don't feel comfortable in terms of escalating. Because what we don't want is a number of organisational or even system issues to be left with the kind of responsibility on the shoulders of a booking clerk or someone who might feel trapped in knowing that they're not able to book patients within the times that they know that they have to, but feeling that the actions that need to be taken are kind of quote unquote above their pay grade. People need to feel comfortable that they can escalate, that it will work, and that they will get the results back. Next slide, please. So taking the meetings in no particular order, we're going to start at the service and then go to the board level. So for the service level meeting, you need to have a PTL report. You need to get that daily because you're dealing with things. If you're booking patients from one day to the next, you need to know each day where people are and who needs what booked. The meeting needs to be chaired by the person who has oversight of that particular bit of your organisation, whether it's a service or a team or a specialty or intervention or whatever it is that you call it. And you should try and have that PTL meeting in a consistent time and location each week, whether that's online or physical or whatever it is you choose to do, so that people know that everyone knows that at 10 o'clock on a Tuesday or whatever it might be, that there's an expectation that they'll be at the meeting and they'll be prepared and they'll come there with their answers. In that meeting, as Paul said, you should not be just reviewing the people that are waiting a long time. We should also be looking at some supporting KPIs that I'll talk a bit more about later, in terms of the shape of the PTL, your demand, your DNAs, those sorts of things. So you're getting a full picture of how the service is working. And realistically, you want to have this in some way coordinated with your organisational PTL. So if you have your organisational PTL on a Wednesday, have your service one on a Tuesday, or whatever it might be, so that you're kind of looking at a consistent picture and you're not looking at a week-old data by the time it comes to your organisational PTL. Next slide, please. So to prepare for a PTL meeting, so if you're an attendee, if you're a booking clerk, if you're a clinician, if you're someone in the informatics team, as Paul said, is a really important part of that picture, you need to make sure that you go to the PTL meeting prepared. Again, a lot of this is really just good practice for meetings generally, but particularly for the PTL meeting where it's fairly quick fire, where it's fairly fixed agenda where the questions are repeated week after week. And I've chaired PTL meetings for many years in my career, and to a certain extent it does get, as Paul said, it does get a bit boring if you just ask the same questions over and over again. You've got a different group of people in each cohort and you need to take those actions accordingly. But you need to come to the meeting with answers, not with questions. So if I'm chairing the meeting, I'm going to want to know everyone who's waiting over a particular length of time. I'm going to want everyone who hasn't got a date. I'm going to want to know everyone who needs X, Y, and Z. If you're attending that meeting, I want you to give me the answers to those questions. I don't want you to take away an action to go and find out. Your preparation for the meeting is to find out, because you know what the questions are going to be. And then we're in the meeting, we ask the question, we get the answer, and we agree the action. So you need to arrive at the meeting understanding what your performance is, understanding any progress in terms of actions, understanding where you are on any trajectories that's been agreed, understanding who your people are that are waiting too long, and with an outline plan about what you want to do about it. And if you can't do anything about it, then it's PTL is the place where you can escalate that, and you can then not have that responsibility because you know you've done your best and you've carried out your actions, and now it's being escalated to the next level up. That's the purpose of the meeting, to get things done quickly at the right level. You also need to have some of the broader context to make sure that you've got an understanding and you're able to articulate any issues around capacity, staffing, any admin processes that are going wrong, or whatever else it might be. So again, you can have that focused conversation in the meeting. Next slide, please. So then after your service level meeting, you then got your divisional meeting. It's basically the same thing, just at a different point of the organisation. So all the people, or not all the people who are leading the service level meetings then are the attendees at the organisational level meeting. That should be chaired by your director of operations or coup or someone like that, whatever those job titles are in your particular organisation. You need to make sure you've got your general managers or service managers or whatever they're called there, so that the right people are at the meeting to give that up-to-date information and to take actions where appropriate. And again, if it needs to be escalated, that's where from the team meeting you can say, we've done our best to do something about this, we're not able to do it, we're now escalating this to organisational level to get some kind of either a bit more oomph behind it, or to get some bigger picture action that's potentially affecting multiple teams. Again, you need to have your daily PTL report, and like every good meeting, you need to have a formal terms of reference, an agenda, so everybody knows what to expect, knows what the questions are going to be, and is able to arrive with the information that they need. And again, you need the PTL, but you also need your data quality reports, your KPIs, and so on and so forth. So if you haven't had a PTL meeting, and from that Menti, it looks like most of you haven't had a PTL meeting, then you might be kind of thinking, what does that really look like? And I guess this is just some sort of tips in terms of how you chair that meeting. So, and obviously, in a very kind of functional level, you're basically turning the PTL and the terms of reference into action. So it's about making sure that the meeting runs on time, making sure the agenda's followed, making sure the right people are there, and making sure that all the different bits of your organisation are represented: operations, informatics, booking, etc., etc. Making sure that all the teams are there, making sure that you take attendance, because later on we'll talk about kind of the functioning of the PTL as being just as important as what happens in it. Making sure that you've got the most recent report and that you know what questions you want to ask. So as a chair, you need to do your prep as well as the people attending the meeting. And then as part of the role of the chair, it's about synthesizing the messages that you're getting from different bits of your organization or from your team into some of those key messages and kind of key themes that might then need to be escalated up to the next level of the process. You also need to make sure that because you as a chair are also attending the kind of strategic board or access board or waiting times board, that you're reporting back down to the people attending that meeting so that they can understand what's happening strategically and where you escalated from your meeting up to the next level, making sure that you're reflecting back so that people know that their escalation has been effective. So if you want to set up a meeting and you want to develop a terms of reference, an agenda, and so on and so forth for your own PTL meeting, if you look on our futures site, there's a link there. You can click on that, and we've got templates for a terms of reference and for an agenda. Obviously, you have to tweak those for your own purposes, but there's just something there to get you started, so you're not starting with a blank sheet of paper. Next slide, please. So then you've got the kind of the third level, your access weights performance board. And again, these aren't prescriptive. You might have 4 levels, you might have 2 levels, it depends on the size and complexity of your organization, how it works. It's, it's entirely up to you. This is just an indication. So this is typically would be possibly a fortnightly or a monthly meeting, whereas the PTL would be weekly. So this is more about looking at the kind of slightly longer term trend, looking at a broader suite of KPIs, although consistent with what's being looked at in the PTL meetings, and looking at some of that bigger picture stuff, as well as, of course, receiving kind of escalations from the other PTL meetings that feed into it. Should be chaired at a senior level, and again, it depends on how your organisation works. This might be chaired by the COO, the organisational one might be a deputy COO or whatever else it might be. This might be chaired by a member of your exec board who's taking a slightly more strategic look at things, a director of strategy or transformation or something like that. And it needs to be supported by, again, a broad suite of KPIs. And where you've got KPIs, as I said, they need to be looked at consistently. So if you set an organisational objective to deliver all, first appointments within 6 weeks, then everybody needs to have a KPI. How many people have had their first appointment within 6 weeks? And if you've got an accurate PTL, in terms of looking ahead, you can say how many people next month will have received their first appointment within 6 weeks, because people will have dates and you'll know what's going to happen. It's also looking at kind of trajectory. So if you've got recovery plans, as Paul said before, if you've got waiting list size targets about where people are in terms of backlog reduction and so on, if you've got targets for the number of people that can breach, looking at breach reasons, etc. You should be looking at a wide suite of indicators so that you can have some of those strategic discussions and say, actually, we've got a bit of a hotspot here, we've got something that's happening here, what can we do at an organisational or system level to look at this pathway, to look at that process, to try to give support to the operational teams in a slightly kind of longer term sense to try to bring about improvements. As ever, you need to have a terms of reference and agenda and so on. Please do check on the futures site for that. Next slide, please. With the best PTL process in the world, people will breach. And indeed, there are some perfectly good reasons for people to breach a waiting time standard. So it's not necessarily a disaster. There's no way any system can have 100% people being treated in exactly the waiting time that you want, because people are not machines, and a hospital or other healthcare setting is not a factory. So it doesn't come out exactly as you want it to when you pull the levers. However, it's important to understand where things don't go according to plan, why that is. And what can be really helpful is having a regular breach analysis meeting. Certainly in most roles that I've done, this has been kind of done monthly rather than on a weekly basis, but it's entirely up to you what works best. So this is about looking at people who have breached and people who are going to breach soon. Because if someone's breach date is next week and you know they haven't got an appointment for another month, then pull out all the stops that you can to try and bring that appointment forward. But it's quite possible that something's gone wrong on that patient's pathway already. This is about looking at your most recent 10 people that have breached a standard, or 20 or 100 or whatever is an appropriate scale, looking at the size of your service and saying, what can we learn from this? It's important to note, if your demand and capacity are not aligned, so if you know you haven't got enough capacity, there's a risk that you can spend your breach meeting analysing 20 pathways and saying in 20 occasions we didn't have enough capacity. That may well be true, but it's important to say that even if you had enough capacity, a bit on some of those pathways, things probably didn't go according to plan anyway. So if you haven't got enough capacity, it's important to acknowledge that, but kind of move it off to one side and say, what are the other things in this pathway that we could have done better? So the meeting is all about understanding how delays can be prevented in the future and making improvements. What do we think was going to happen? What actually happened? Why did it happen? What can we do differently next time? What can we learn from this? How can we create this thematically to try to make some changes? Like any effective meeting, having an action plan with timescales, people responsible, making sure that's followed up from one meeting to the next. Reports from the meeting should also feed into you, and learning from the meeting should feed into your PTL meetings. And we've also got a template on the future site about carrying out after action reviews. Next slide, please. You'll see here we've just got some examples. Just this kind of simple way of visualizing some of the sort of thematic learning you can take from looking at breaches. So we looked across an entire service at the most recent, I can't remember what it is, 50 people that breached a particular waiting time standard, and looking for what the themes are and where in the service they occurred. So this is the sort of thing that you might look at as a kind of headline for your breach meeting, and it might also potentially feed up to your access weights board as a kind of looking at where the pinch points are, where the themes are. I can very quickly look at this and say the pinch points are DNAs for first appointment and first appointment capacity in psychology. Obviously, this is just made up, but very quickly, instead of having to look at a long list of people, I've just looked at this and seen two things that I want to focus on at a strategic level. Okay, so I'm going to hand over to Francis now for another Menti.
Yep. Thanks, Michael. And so where you have people waiting too long, what sort of level of investigation do you deploy to learn as to the reasons why they're waiting too long? Do you sort of look at general themes, after action reviews, as Michael just mentioned? Is it a systems-based patient safety investigation that you use, RCA type of thing, or do you investigate it as a serious incident? Right. So most people are converging towards investigating general themes, smuttering around systems-based patient safety investigation, some RCAs, but it seems like there's a sort of a strong theme emerging around sort of investigating, looking into general themes, but there's also a cluster of people who generally do not conduct investigations. So Simon, if you would talk us through how we deal with that.
Sure. Thank you, Francis. Can I have the next slide, please? So, identifying, reporting on, and responding to patients waiting a long time for treatment needs to be embedded across the routine patient safety priorities and associated quality governance processes within the organisation. Not aware of any providers who don't have a long waiting list for one or more of their services or treatments. So this is in part about managing active risks. However, even if there weren't any long waits, managing waiting times isn't static, and it isn't ever an activity that can be considered complete. So you will need processes that are sensitive to picking up when this is happening and responding to it effectively. And there's a number of different steps that need to be considered when thinking about how this is managed. The first being developing locally determined thresholds for what constitutes a significant breach in delivery of the waiting time standards. And you need to think about that from both a service delivery issues perspective and individual patient waits. So from having a group activity trigger, so if you have a standard where 75% of your patients are supposed to enter treatment within 6 weeks, and 95% of patients are supposed to enter within 18 weeks. If you fall below the 95% within 18 weeks point, then it's the likelihood is that something's going quite seriously wrong, and you're going to want to consider that a serious problem. Similarly, you will want to set a threshold for what would constitute the maximum sort of tolerable waiting time for any individual. So if I'm just picking these entirely out of the air, if you had a 4-week standard and you had somebody who had been waiting for 18 weeks, you may want to consider that a serious breach. You will then also need, secondly, processes for investigating, responding to, and learning from long waits. Now, moving forward, that should form part of your patient safety incident response plan as people implement the patient safety incident response framework, and we'll need to use systems-based investigative approaches to looking at these. The things you will need to consider are having the process to review what the serious breaches of waiting time standards, how decisions will be taken around identifying learning when you're looking at a breach or breaches, how that will be aggregated, thematically understood and shared, and what standards for training and practice are you going to have for the managers undertaking system-based reviews. Thirdly, you'll need to have a defined maximum acceptable waiting tolerance. So at how much longer than the waiting time standard could a patient wait before they are at risk of harm? So this is the point at which you would need to undertake a clinical harm review. So it's likely to vary from pathway to pathway. For example, a patient who has breached a waiting time of 72 hours by 24 hours is probably of greater concern than a patient who has breached a 28-day waiting time standard by 24 hours. So you need a clinical harm review trigger. You'll also need a transparent clinical harm review process to determine whether a patient has come to harm due to elongated waiting. And the 4 questions that you want to consider within that review are: has the delay meant the patient has had to have a more intensive type of treatment or a longer period of treatment than first anticipated? Has a delay meant that the progression of symptom severity has precluded some treatment options that would have otherwise been applicable? Has the delay in treatment meant that the patient has a loss of functionality that is greater than could have been anticipated from their disorder? And fourthly, has there been any prolonged psychological harm experienced? So, over 28 days is the general threshold for that. Fifthly, you'll need a clinical harm review governance process to receive, review, and coordinate responses to clinical harm reviews. This should be linked into your patient safety processes for overseeing harm, be it moderate harm and serious incidents currently, or in future, your group overseeing the patient safety incident response plan issues. And finally, you'll need keeping in touch processes for where there are very long waits, with thresholds described in policy and operating procedures about when these are to be implemented in pathways. Could I have the next slide, please? And I'll hand back to Frances.
Thank you. So in relation to waiting time standards, do you have defined standards for what constitutes a serious breach for a group of individual waiting times? Do you have defined thresholds where clinical harm reviews are instigated in response to long waits? Beg your pardon. Do you have routine breach analysis processes for serious breaches? Routine clinical harm reviews for serious breaches? Or clinical panels reviewing harm from breaches, or keeping in touch processes? So it looks like most people so far who are answering have keep in touch processes for proactively monitoring people waiting for a long time. And this is followed by defined standards for what constitutes a serious breach. So we've sort of got that sort of general dichotomy and a smattering around routine clinical harm reviews, or defining thresholds for clinical harm reviews where they're instigated. So yes, keeping in touch processes are the most popular. Please continue to pop questions in the chat box. Thank you. Over to you, Michael.
Thank you, Frances. Next slide, please, Louise. So, in terms of measuring success, so I mentioned, and Paul did as well, so I'm not just making it up, that it's important to be looking at a wider suite of KPIs than just your PTL. Although getting the PTL right is obviously absolutely crucial and can be the underpinning for a number of other ones. So how do you know that your PTL process is working? And these are some of the questions that maybe you want to be asking at the kind of strategic board level. Is, how many people are breaching per month? Hopefully that number will be going down, and you could be looking at that as a raw number, or possibly as a proportion of your waiting list size. And we talked about making sure that people receive equitable treatment subject to clinical urgency. So maybe looking at some indicators like the proportion of people who are taken within date order. So you're identifying if there are any kind of outliers in terms of appointing people in some sort of maverick way. A number of data quality measures. So if you know you've got particular problems around a particular bit, whether it's making sure that appointments go on the system in a timely way, making sure that appointments get outcomed if that's how your EPR works, making sure that people get their intervention that they're waiting for recorded rather than just waiting for an unspecified thing at an unspecified time. If you've got particular problems with data quality, develop your own KPI and make sure you're keeping track of those. Some pretty standard ones in terms of the waiting list size, any waiting list reduction trajectory, any actions need to be taken to do that. You can also look at clearance time, which I think I mentioned on one of the previous webinars, which is a really useful way of measuring waiting list sizes across different sized teams and departments. But in terms of process as well, you could be looking at making sure for your PTO to work, the right people need to be at the meeting to take the actions to actually get things done. So auditing, keeping an attendance list for each meeting and auditing that and making sure you don't get any kind of repeat offenders in terms of DNAing their own meeting can be a really powerful tool to make sure that the process works properly. Proportion of actions that actually get carried out on time. Each action needs to have an owner and a date. Was that achieved? And also importantly, looking at patient satisfaction. So I'll talk a bit in a minute about developing waiting time standards in conjunction with patients and other key groups. You need to make sure that people are actually happy with the service that they're receiving, something beyond the friends and family test, ideally. Next slide, please. Got an example here. I mentioned before that I worked in an acute trust as a head of recovery, and this is the dashboard that we developed in terms of how to restart our endoscopy, radiology and surgical activity based on some really quite tight management of limited theatre capacity due to all of the face masks and aerosol sprays and all that business, changing the air in theatres and so on. Anyway, so it was really useful for us at board level to be able to demonstrate at a glance where we were against our plans, where we were in terms of activity, capacity, where we were against our SLA, because obviously in acute care you've got much more explicit activity levels. And where you were year to date in terms of overall delivery, because of the financial implication for that as well. And that's cut across kind of different areas of the system. So although this is an acute care, just as easily, I hope you can see something like this, giving you that at a glance view, could be used really effectively to support the delivery of elective recovery and mental health services. Just substitute the specialties for teams, substitute the day case and inpatients for different types of intervention, and you very quickly could use a similar approach in mental health. And having this kind of at a glance to support meeting gives you real ability to drill down to the most focused bit of a discussion when you're looking across a whole organisation. I'm going to pass over to Francis now again for another Mentee. They're coming thick and fast.
Indeed, and by now you're all experts. So obviously you would recognise some of these waiting times, which are national waiting time standards. And so the question here is what you actively monitor in your organisation. So hopefully the first few will be familiar. But do you additionally, for example, monitor waiting time standards within your adult community teams or any other sort of national quality standards, such as the ones relating to veterans, looked after children, perinatal, or do you indeed have any sort of local standards that you monitor? So this is, you can sort of choose all options. Obviously, it won't be one or the other because some of these are, as I said, national waiting time standards. So IAPT is very recognisable, obviously, and followed by EIP and CYP. And but some of you are monitoring some standards in adult community teams. And it seems like some of you are struggling to sort of select more than one of these. The Mentee is supposed to allow you to select more than one of these, so apologies. But by all means, if you are sort of monitoring any local standards, we'd like to hear about them. We'd like to hear from you generally, so don't be shy, and we're expecting a very active discussion after that. But in general, you can see here that IAPT is the most well-known waiting time standards people are monitoring. Thank you.
Thanks, Francis. That's good. I was getting quite alarmed about the EIP answer, to be honest. I thought EIP waiting time standard has been around for quite a long time now. If only 4 organisations are tracking it, then we might as well all go home. Right. So sorry, we had a technical problem there. But anyway, I guess the point that really wanted to make with that was, obviously you've got all these national must-dos. Everyone knows about IAPT, and I would like to link the fact that tracking IAPT waiting times has a greater profile in a lot of organisations because IAPT has better data. If you have better data, you can track people better and you can deliver shorter waits. There's a very clear link there. But all of those are mandated. But really what we want to try and say to you is you should track everything. There's a temptation to sort of criticise national focus on particular areas and say, what about everybody else? But as organisations, as systems, you don't have to just do what you're told that you have to do. We would really encourage you to be tracking every pathway. Even if you put aside the kind of equity and patient experience angle, which I would suggest you do not do, from a corporate assurance point of view, you need to know that you have got eyes on everybody who's waiting for something. And if there's not a nationally set standard, then we'll talk a bit about how you can set your own standards. But ultimately, all services and treatments should have visibility to you as an organisation, whether that's to you as a chief executive, to you as a COO, to you as a general manager, to you as a service manager, or to you as a clinician. All the people under your aegis need to be tracked and need to have visibility because you need to be assured that they're getting treated as quickly as possible. And as I've really hammered home, I hope, that includes treatments after the first appointment, the whole pathway, not just your first appointment or assessment or whatever it is you call it. Next slide, please. So if you don't have a nationally defined waiting time like IAPT or EIP or eating disorders or whatever it might be, then there's nothing stopping you, and we would actively encourage you to set some general expectations. It might be that just as an organisation you say everyone who's not on some other nationally defined thing needs to have their assessment within 4 weeks or 6 weeks or 10 weeks or whatever you choose, and that will be determined by all sorts of factors. Or it might be that you want to prioritise particular things that you think are locally relevant and important. So this needs to be agreed not just for you as an organisation in terms of what's deliverable based on your current capacity, based on your current performance, but also agreed with local stakeholders, ideally as part of your access policy process, where you should be engaging with people anyway. And my colleague Sarah will be leading our access policy module and webinar, 9:30, 31st of January. Be there, or be square. And we would really encourage you as part of that process to be laying out where the nationally mandated waiting times are and having a real discussion about what people think is reasonable. And maybe your patient group will say we want everything tomorrow, and there needs to be a pragmatic discussion about what's deliverable. But it might be a really good starting point for you as an organisation to say, right, having done some engagement with patients, families and carers, there seems to be a reasonable expectation that you should have an assessment within 6 weeks or whatever. We're currently at 57 weeks. And then you then have that conversation about, right, what intervening milestones are we going to set as a system, as an organisation? How are we going to get there? And you can have an honest conversation with patients and patient groups and say, look, we're currently at 57 weeks. We want to be at 6 weeks. We're not going to be there tomorrow. Here's a plan. Here's our trajectory. It's going to take us 1.5 years, but that's where we're going to get to. And then you can evidence and track that through your board. And then that percolates down so everyone's pulling in the same direction up and down your escalation process and your governance structure. Anyway, key points in terms of developing your own waiting time standards and measuring waiting times generally. The waiting time that you measure, the clock we generally call it, should reflect the experience of the person who is accessing the service, not the experience of the service itself, but not the experience of you as an organisation. So people should be given a choice of dates if you're making an appointment, and all of those choices should be within the maximum waiting time standard. If you offer one choice that's within the maximum waiting time standard and two afterwards, and people choose the later dates, that's your fault, that's not their fault. The clock doesn't stop. If someone cancels or DNAs an appointment, whether that's within your DNA policy and process or not, that's reflected within their wait. They still haven't received the thing that they need, so the clock keeps ticking. If someone goes on holiday, they still need the thing that they need, and the clock keeps ticking. These things may well be reflected, as I showed earlier, in your breach review process. It might be you identify we've got a large number of DNAs. You might want to then work out how you try to improve that through all sorts of things in terms of offering better choices, text message reminders, all the usual stuff. But the clock keeps ticking until the person gets the thing they need, because you want to understand how long people are actually waiting, not manufacture a waiting time to fit a standard. And finally, as I've really emphasised, I hope you to understand what it is the person is actually waiting for. Someone's referred with anxiety, they're waiting for the first line intervention for anxiety. They're not waiting for a triage. So even though administrative milestones might be important for you as an organisation, they're not important for patients, and you should be measuring the time from when they get referred to when they receive the thing that they need. Okay, brief but I hope clear and directive in line with feedback. So without further ado, I'd like to hand over to Simon, who can deal with the outro and then launch us into our Q&A session.
Oh, I forgot we've got a word cloud. This is my favourite bit. So this is our, I think, the final Menti for today. We hope that you found this useful. If you could please provide us with some feedback, we'd be really grateful on what has been most helpful. As you would have seen at the beginning, we triangulate all of the stuff that you say to us in the feedback forms and the Menti questions to think about how we pitch our future webinars, and yeah, so we'd be really grateful for your feedback. Good. I see Michael's clarity around structure and directiveness around meetings and data have been well received, so that's always good. I think it may be next in the new season post April we look at doing some further webinars. We may focus in more on the quality governance stuff, or some of the detail that we haven't had opportunity to put through in some of these. It's great to see structure leaping out. That's what gets us up in the morning. Fabulous. Thank you all. It's all heartening messages for us.